Hello everyone, welcome to my YouTube channel. My name is Prahlad Gupta and I'm currently a fourth year medical student at Institute of Medicine Maharajganj Medical Campus. And today in this video, I'll be discussing on a question from gynecology, and the question is why salt restriction is not recommended in gestational hypertension uh, or preeclampsia. So before understanding this question, we have to understand two main concepts that what is the relation between salt intake and blood pressure, and what is the basic pathophysiology of hypertension in pregnancy. So by understanding these two concepts, then we'll be able to understand why salt restriction is not recommended in gestational hypertension or preeclampsia. So here is an article that shows that there is a close relationship between hypertension and right sodium intake. It says that prolonged modest reduction in salt intake induces a relevant fall in blood pressure in both hypertensive and non-hypertensive and normotensive individuals. It says that high sodium intake and the increase in blood pressure levels are related to water retention, and it is due to increase in systemic peripheral resistance, alteration in endothelial function, and change in structure and function of large elastic artery, and also due to the modification in sympathetic activity and in autonomic neuronal modulation of the cardiovascular system. Let's understand this mechanism by this uh, diagram. So it says that when there is high sodium intake, it causes increase in systemic vascular resistance, and thus increase in systolic blood pressure and diastolic blood pressure. So it basically causes increase in reactive oxygen species, and there is the state called oxidative stress. So it causes endothelial dysfunction, and thus the decrease in synthesis of nitric oxide. As we all know that nitric oxide is an vascular like a vasodilator, and so if there is a decrease in nitric oxide, there will be vasospastic feature, and thus the increase in systemic vascular resistance. There will be also effects in the large elastic artery, like there will be activation of the extra cellular matrix metalloproteinase, and there will be fragmentation of elastin fibers and accumulation of the collagen fiber. This leads to the decrease in elastin collagen ratio, and which result in eventually increase in arterial stiffness that causes uh, increase in systolic blood pressure. So this is the basic mechanism. It shows the relation of the salt intake and the blood pressure. And now let us understand the etiology of hypertension in pregnancy. So we have the two important terms, that is trophoblast and uterine vasculature, uterine vascular changes. So trophoblast is a part of fetus, and uterine vascular changes. It is like a part of mother. So there is a fetal mother interaction. Normally, there is invasion of intravascular trophoblast into the wall of spiral arterioles of uteroplacental bed. So in the first trimester, that is the 10 to 12 week, the intravascular trophoblast invades the up to the decidual segment, and in the second trimester, another wave of trophoblast invades up to the myometrial segment. So during this phase, this replaces the endothelial lining and muscular arterial wall by fibrinoid formation. So this is the main thing is that there is the replacement of there is there is replacement there is replacement of the endothelial lining and muscular arterial wall by fibrinoid formation. The spiral arterioles thereby becomes distended, tortuous, and funnel-shaped. These physiological changes transforms the spiral arteriole into the low resistance, low pressure, and high flow system. Why is this happening? So this is all happening to increase the blood supply to the fetus, which is required during pregnancy. So this is the normal physiological change that is going to happen in every pregnant woman. So if if there is interruption in, if there is any abnormalities in this physiological change, then the hypertension is going to develop. So let us understand this by this diagram. So till now we have read that in the normal pregnancy, that is after 20 weeks, there is a trophoblastic invasion and replacement of the smooth muscle layer of the spiral arterioles that causes vasodilation. That is, so this is in this diagram. This is maternal villi and this is fetal villi. So this is a spiral. This is the part of spiral arterioles. And now let's understand this. So this is intima of the spiral arteriole. This is media and this is adventitia. So basically, what we read is that there is a replacement of the smooth muscle layer of the spiral arteriole. So this smooth muscle layer, this smooth muscle this smooth muscle layer is going to be replaced. So what is going to happen is that if this smooth muscle layer is going to replace, so just imagine there is a muscle layer and that is going to be replaced, then it will be like then the arterioles will become distended, tortuous, and it will be low resistance and low pressure and high flow system uh, that will eventually lead to the sufficient blood supply to the fetus, and that is going to favor the growth of the fetus. So this is the normal physiology. But if there is persistence of the there is the persistence of a smooth muscle layer, or there is inadequate trophoblast invasion, then there will be retention of this smooth muscle. Normally, this muscle was replaced, but now there is persistence of a smooth muscle layer, and there is inadequate trophoblastic invasion. Then there will be a condition called vasospasm of spiral arterioles of uterus. So when there is vasospasm of the spiral arterioles, there will be compensatory increase in maternal systemic blood pressure to increase the blood supply to the fetus, which manifest as gestational hypertension and preeclampsia. So let us imagine there is a spiral arteriole in a spiral arteriole in a maternal uterus that is via which blood was passing to the fetus, and in the normal physiology that arteriole was supposed to dilate, but due to some problem, that is due to the that is due to persistence of a smooth muscle layer or inadequate trophoblastic invasion, this replacement of a smooth muscle is not going to happen. So what is so if there is no replacement of a smooth muscle layer, then there will be vasospasm. So if there is vasospasm, let us imagine that there is a there is a pipe, and if we constrict the pipe, then there will be a back pressure is going to arise. So the maternal system hemodynamic system compensatory increase their maternal systemic blood pressure to increase the blood supply to the fetus. So this increased blood pressure will manifest as a gestational hypertension and preeclampsia. So this is how this is all about how pregnancy is hypertension is going to develop. So our main question was why salt restriction is not recommended in gestational hypertension. So till now we read about how salt restriction like like how salt intake increases the blood pressure, and how salt intake increases the blood pressure. That is, I am talking about systemic hypertension, not pregnancy. It increases the blood pressure, and that is systemic hypertension. It causes systemic hypertension, and restriction of the salt decreases the risk of uh, systemic hypertension. So, but in pregnancy, there is no role of salt restriction. So now let's talk about why there is no role of salt restriction. So we suggest salt restriction in a systemic hypertension. We suggest salt restriction in systemic hypertension, not in like gestational hypertension or preeclampsia. We suggest salt restriction in systemic hypertension to reduce water retention and thus blood pressure. We are suggesting the salt restriction so that to reduce the water retention, and thus the blood pressure is also going to reduce. But in pregnant lady with gestational hypertension or preeclampsia, there is compensatory increase in maternal blood pressure to supply the sufficient blood to the fetus. So let us suppose a pregnant lady, due to abnormal trophoblastic invasion or replacement of the replacement of the smooth muscle layer of the spiral arteriole, the mother is going to develop a gestational hypertension. So why that hypertension is being developed? To compensatory, it is compensatory increase in blood pressure of the maternal system to increase the blood to the fetus. So, but if we do salt restriction in this condition, there will be decreased water retention, and the systemic blood pressure will also decrease, which might cause fetal insufficiency. So there was a compensatory increase in blood pressure, and you are doing salt restriction. And if you are doing salt restriction, there will be decreased water retention, and this will decrease the blood pressure, but it might lead to the fetal insufficiency. Like that is, the blood supply to the fetus might decrease. So this may hamper the child. This may cause the intrauterine growth restriction. So salt restriction is not recommended in a pregnancy induced hypertension or pre-eclampsia. So thank you. So these are our references that I have taken for this video. Thank you. See you in the next video.